and welcome to the AtNet Memory Clinics webinar. It's the second webinar this year in a kind of revived webinar session after a one-year hiatus. And I'm very glad to welcome Louise Mewton today, who will talk to us about alcohol use in older adulthood, physiological impacts and effective treatment options. Before I hand over to Louise, I will just do some general AtNet advertising and housekeeping. So first of all, I'd like to start by acknowledging the country on which we're meeting today. The Australian Dementia Network acknowledges the traditional custodians of country throughout Australia and the continuing connection to land, sea and community. We pay our respects to all Aboriginal and Torres Strait Islanders, peoples, their cultures, and to their elders past, present and emerging. I'm joining today from Bedigal Land. Probably most of you are pretty familiar with what AtNet is right now, but just as a brief update and to everyone who might join our webinars for the first time today, welcome. The Australian Dementia Network, or short AtNet, is a national network of dementia research experts and health professionals with like three main initiatives involved in here. One being AtNet screening and trials, aiming to establish a highly characterized trial-ready cohort. So they're really registering all volunteers with dementia and care partners ready to go into trials to speed up trial recruitment across Australia. We have the AtNet Clinical Quality Registry, who set up the first clinical quality registry for dementia in Australia, currently still recruiting clinics who want to join the registry, entering data with their broad vision of one day really capturing every single person with dementia that gets newly diagnosed in Australia. So I will have a link for you to join up with the registry and get in touch with the team in a minute. And our initiative AtNet Memory Clinics. So we are looking at harmonizing assessment standards, providing national guidelines, providing training, and really kind of looking at health professionals and memory clinic clinicians, dementia specialists, and also patients and care partners in the health system and how we can improve health pathways for people with dementia. We were initially NHMRC funded. That funding ended in June 2023, and we are on ongoing support currently from the Department of Health, so we can continue some of our projects at the moment. As I just mentioned before, you're more than welcome to consider joining and engaging with AtNet more broadly. Particularly AtNet Registry is happy for everyone reaching out, wanting to join the registry so they can really achieve their mission of capturing every person with dementia and MCI. Please feel free to reach out to the AtNet Registry at monash.edu.au. Sorry, we copy that correctly into the chat when and everyone can reach out if you want to know more about the registry. You can also get to this bit.ly link, AtNet list, if you want to register your clinic onto our AtNet locator. If you want to stay up to date with the latest AtNet news, you can subscribe to our newsletter. For that, you just head to the AtNet website and you will get added to an email mailing list. There is a link there that you can follow to add yourself to the mailing list, which probably most of you have done when you're joining this today and have seen our invitations for this webinar today. And if you run or work in a memory clinic and you want to stay up to date specifically with the work that we're doing at AtNet Memory Clinics, there's also a red cap link for you to join our specific mailing list, which will have some extra side notes on memory clinic specific information. For example, side notes like this one, we just published or launched our updated Memory and Cognition Clinic Guidelines version 2. The initial version was published in November 2021. And since then, we received a lot of feedback from clinicians across Australia and from patients that led to some improvements that we've done to the guidelines. And we are very happy to announce that the new version is out now. You can follow this link, go on the AtNet website, and you'll easily find the newest version of the guidelines. This version now has newly added sections that include standards tailored to the needs of culturally and linguistically diverse clients and clients with intellectual disabilities. Both these sections were developed in consultation with clinical experts as well as patients with the lived experience of dementia there. So we try to get as much expert input as possible to publish these standards. We also revised the guideline structure a little bit more, made it a bit more concise, and tried to follow the feedback that we received from clinicians. There will be a chance for consultation, a very brief survey that gives you the option to provide as much or as little information and feedback as you would like to leave us for the guidelines. Please reach out. We're happy about any feedback that we receive so we can keep making improvements to this document. So without further ado, I'd like to introduce Associate Professor Louise Mewton, who is an Associate Professor and Public Health Researcher with a focus on epidemiology, assessment, prevention, and treatment of alcohol use and related disorders across the lifespan. She's a program lead in lifespan and brain health research at the Matilda Centre at the University of Sydney. And today she's talking to us about alcohol use in older adulthood, the relationship between cognitive decline and dementia.
Okay, so thank you so much for the introduction. Welcome, everyone, and thank you for coming along today. So I'm going to be talking about alcohol use in older adults with a focus on the physiological impacts, particularly the cognitive impacts, as well as effective alcohol treatment options for older adults. So I'd also like to begin today by acknowledging the Gadigal people, the traditional custodians of the land on which I am presenting from today, and I pay my respects to their elders past and present. I extend that respect to Aboriginal and Torres Strait Islander peoples here today. And I also acknowledge the traditional custodians of the lands from which you are all joining me from. So in terms of key learning outcomes from today's webinar, first I'm going to be focusing on the physiological impacts of alcohol use on older adults. I'm then going to talk about the impact of alcohol use on the brain of older adults, including the relationship between alcohol use, cognitive impairment, and dementia. And then I'm going to be focusing on effective approaches for treating harmful alcohol use in older adults. So first, how do we define older adults? So older adults are defined as those aged over 65 years in the general population, but for some populations, so for Aboriginal and Torres Strait Islander peoples, for example, as well as for people who are attending substance use disorder services, our older adults are actually defined as those aged over 50 years. Now, I also wanted to touch on this here is that we're seeing a change in the demography in Australia, with a greater proportion of older adults in the population. So in 2017, it was estimated that there were about 4 million older adults aged over 65, and that was about 15% of the population. In the next 50 years, it's expected to increase to 9 to 10 million older adults. That's 21 to 23% of the total population. So Australia's population is aging. Now, at the same time, we're also seeing changes in patterns of alcohol use over time. So we have national data here, and this comes from the most recent National Drug Strategies household survey. And we can see that we're seeing some pretty sharp declines in risky drinking amongst younger age groups. But we're not seeing those sort of equivalent reductions in these older age groups. We're seeing that over time, the rates of risky drinking are fairly stable amongst older age groups, and that's over the last 15 years or so. And here we have, again, national data, this time on treatment episodes for alcohol. So this includes alcohol-related treatments such as assessment, you've got counselling, support and case management, withdrawal management, rehabilitation, psychoeducation, and pharmacotherapy. And again, we can see that while treatment episodes are decreasing amongst younger age groups, we can see that treatment rates are increasing among older age groups. So for example, here we have the 10 to 19-year-old age group and the 20 to 29-year-old age group, and we can see reductions in treatment episodes there for alcohol-related problems. Somewhat stable in the 30 to 39-year-old age group, but then as we get to the older adults, 40 to 49, and 50 to 59, and then 60 plus, we can see that treatment episodes are increasing. So this could reflect our aging population or the fact that more recent generations of older adults, so the baby boomers, for example, have had more exposure to alcohol. So what we're seeing is a shift in the demography of alcohol-related treatment episodes, and clinicians are now more likely to be seeing older adults in their care. So here we have different types of older drinkers that may be coming into the care of various services. So these have been taken from the most recent Australian alcohol treatment guidelines. You've got a link to those there. So the first group of older drinkers are survivors, and these are early onset users. And these are people who have developed alcohol use disorder in their youth, and then they prematurely age because they don't use preventative services and may require aged care related services in their 50s. So it's this group that's really contributed to the revision of that definition of older adulthood amongst those seeking alcohol services. We've then got our maintainers, and these are people whose long-term risky alcohol use only really starts to manifest itself as a problem as age-related changes occur, and this previously well-tolerated, although excessive, consumption of alcohol is no longer tolerated or results in harm. So these are people who have been drinking heavily in their youth, and it was fine, wasn't causing particular problems for them in their youth, but they continue to drink in that pattern, and as they get older, it starts to cause harm. And then we have our reactors, or our late onset users. And these are people who develop alcohol use disorders after the age of 50. This may occur in association with issues that are more prevalent in older adulthood. So we've got things like declining health, chronic pain, stress, insomnia, bereavement, unemployment, depression, social isolation, and boredom. And what we know is about 1 in 3 older adult problem drinkers will develop their problem drinking in later life. So 1 in 3 older adults are part of this, 1 in 3 older adults with drinking problems are part of this reactor group. So what we have next are a couple of vignettes really focusing on this reactor or late onset group. So these videos have been produced as part of the Drink Well, Age Well program in the UK. And I think they're brilliant at really putting a face to the problem here.
Welcome to another episode of Vintage Street, where we take a closer look at more mature humans in their natural habitat. We will explore the survival techniques they adopt and how they adapt to their surroundings as they get older. Firstly, let us peek into the nest of lovebirds, Jackie and Derek, returning home after gathering their weekly big shop. Ah, we're seeing this live now. The female produces their weekly supply of booze, 6 bottles. Booze is a favored human ritual for relaxation, despite its link with over 60 health conditions. With their offspring all grown up and having flown the nest, Jackie and Derek are increasingly enjoying their evening tipple as the long evenings stretch out without the busy chirping of family life. Now, viewers, we are lucky to observe the behavior in this lion's lair. Having been the pride of the pack for many years with many responsibilities, this particular species, Kevin, has now retired to live out his life in quiet solitude. Kevin puts his new fondness for daytime drinking down to having more hours to fill. He didn't think his long-anticipated retirement would leave him feeling quite so bored. Our final human species of this episode is Liz. She has become increasingly isolated from her pack since losing her life partner Frank. Liz and Frank were the life and soul of every party, and always the last pair standing. But sadly, Frank died from bowel cancer last year. Liz is using booze for more than relaxation. She is using it to numb her grief and pain. Most painful for Liz is that she can't have her granddaughter, Ada, for overnights anymore. Do you recognize any of the humans on Vintage Street? Harmful drinking is increasing more in the over 50s than any other age group. Life changes we will all go through, retirement, empty nest, bereavement, may trigger us to drink a little more often and a little more than we should. To find out more about making healthier choices about alcohol as we age, go to drinkwiseagewell.org.uk.
Okay, so that video really demonstrating some of the triggers for late onset drinking and how certain life events may lead some older adults to start drinking in a problematic way. So why should we be concerned about risky drinking in older populations? Well, there are these physiological changes associated with aging that may place older adults at greater risk for alcohol-related harms. So the first is that we've got decreases in lean body mass and total body water. And what this means is that for any given dose, someone will have a higher blood alcohol concentration. We also see less efficiency in the liver enzymes that metabolize alcohol as we age. Older adults are also more likely to experience multi-morbidity and associated medication use. They're also more susceptible to the acute cognitive effects of alcohol, and this can lead to things like injuries and falls. But what I am particularly interested in are the chronic cognitive effects of alcohol and the impact of alcohol on things like cognitive impairment and dementia. So in terms of the sort of brain damage that alcohol can lead to, the first I'm going to focus on is Wernicke-Korsakoff syndrome. So this is a serious brain condition that is usually, but not exclusively, associated with chronic heavy alcohol use and severe alcohol use disorder. So it's caused by severe thiamine or vitamin B1 deficiency, and that's due to poor nutrition as well as inflammation of the stomach lining. So the prevalence of Wernicke-Korsakoff's is not well established. It is estimated that it may remain undiagnosed in about 80% of patients. And without treatment, Wernicke-Korsakoff syndrome can be disabling. It can produce permanent memory loss, and it can be life-threatening. So what we have here are MRI scans of a healthy male at the top here, and that's compared with a male of the same age with Wernicke-Korsakoff syndrome. So what you tend to see is that the Wernicke-Korsakoff's brain has less volume overall and these larger cavities or these ventricles in the brain. So Wernicke-Korsakoff's can result from other conditions that involve malnutrition. So things like cancer, AIDS, excessive vomiting that might be associated with pregnancy, as well as gastrointestinal or bariatric surgery. But these cases are far less prevalent than those associated with severe alcohol use disorder. Sorry about this, my pointer is not behaving. So early symptoms of Wernicke's disease can be reversed if detected and treated promptly and completely. So the symptoms of Wernicke's include things like confusion, a lack of energy, hypothermia, low blood pressure or coma. There's also a lack of muscle coordination that can affect posture and balance and lead to tremors. And there's also these vision problems. So things like abnormal eye movements, double vision, this misaligned or cross eyes, and eyelid drooping. So Wernicke's disease should be considered a medical emergency. It's treated with intravenous administration of vitamin B1 and glucose. And although some of the symptoms of Wernicke's, such as the muscle and the vision problems, are reversible with prompt thiamine treatment, other symptoms may respond more slowly or may not recover completely. So without prompt treatment, Wernicke's disease can then progress to Korsakoff's syndrome, which is not reversible. So symptoms of Korsakoff's include potentially severe, irreversible memory impairments, including problems forming new memories, as well as recalling old memories. There's this confabulation, it's a making up of inaccurate stories about events or remembering events incorrectly. Hallucinations may be experienced. There's this repetitious speech and actions, severe problems with executive functioning, as well as a lack of motivation and emotional apathy. So in Korsakoff syndrome, severe memory loss and other brain damage could become permanent. So treatment for Korsakoff, again, includes intravenous vitamin B1 replacement therapy, as well as other oral supplements for several weeks. So aside from this B1 therapy in the short term, there's no one optimal treatment for Korsakoffs. Treatment often varies depending on the symptoms, severity, and other co-occurring deficits. So things like psychosis or other major psychiatric disorders which might be present as well. So memory rehabilitation therapies, similar to those provided for various forms of dementia, can be effective in lessening the symptoms of Korsakoffs, but severe cases often require residential care. So in addition to Wernicke-Korsakoffs, we also have criteria for an alcohol-related dementia that have been proposed. These were proposed quite some time ago, but they still require more formal validation. There's still some controversy over whether this primary alcohol-related dementia exists. So while the impact on the brain in Wernicke-Korsakoffs is indirect, it's through that impact on thiamine depletion that then has an impact on the brain. In alcohol-related dementia, it's thought to result from the direct neurotoxicity of alcohol. So the criteria include a cognitive impairment that alters independence in activity of daily living. There needs to be evidence of really quite heavy alcohol use over a sustained period of time. It's supported by the presence of other alcohol-related organ damage. So this could be liver damage, for example, as well as by ataxia, which might be attributable to brain atrophy. So you can have evidence from neuroimaging supporting a diagnosis of alcohol-related dementia. So with alcohol-related dementia, cognitive impairment and brain atrophy can improve with extended abstinence. So it's not necessarily a degenerative disease. And it's discriminated from Alzheimer's through better performance on things like semantic and verbal memory tasks, but then poorer performance on visuospatial tasks. So visuospatial ability is really impacted as a result of chronic heavy alcohol use. So there is evidence for alcohol-related brain disorders, whether that's through the direct neurotoxicity of alcohol or through indirect pathways, such as through thiamine depletion. But there's also recent evidence suggesting that chronic heavy alcohol use, specifically here alcohol use disorders, are quite strongly related to all-cause dementia, including Alzheimer's dementia. So this was a French study of over 31 million adults discharged from hospital. So this is a hospital record study. Over 1 million of those people then went on to be diagnosed with dementia. And what they found is that 60% of early onset dementia cases were directly alcohol related. So a really strong relationship there between alcohol use disorders and early onset dementia. Alcohol use disorders were also the strongest modifiable risk factor for all-cause dementia. That you can see that there, and that's compared with more sort of established risk factors. So things like high blood pressure and less education, for example. So we can see that chronic heavy alcohol use and alcohol use disorders are associated with quite serious brain disorders, including dementia. Alcohol use is also related to cognitive impairment more broadly, including impairments that may not be at the level of the disorders that we've discussed so far. So it's estimated that about 50 to 80% of those with an alcohol use disorder demonstrate really significant cognitive behavioural compromise. And about 30 to 40% of those demonstrate compromises at the level of clinical impairment. Alcohol impacts cognitive functioning in multiple domains. We see it impacting executive functioning, visuospatial functioning, gait and balance, new learning and memory, as well as emotion processing and social cognition. So we saw earlier the brain correlates of Korsakoffs, but even cognitive impairment that doesn't reach that level of disorder is associated with impacts on the brain as indicated in neuroimaging studies. So neuroimaging studies, including some of our own, have shown that alcohol-related cognitive impairment is underpinned by things like loss of brain volume in grey and white matter, particularly in those frontal areas, compromised white matter integrity, you see these larger ventricles, and you see compromised brain activity and connectivity when using functional MRI. But on a positive note, we also know that recovery from alcohol-related cognitive impairment is possible. So these are results from a meta-analysis of 62 studies, so a big meta-analysis here. And what they found was that abstinence, so no drinking at all, sustained for 12 months resulted in cognitive improvements across 11 domains, and that was in a small to moderate effect size improvement. So substantial improvements tend to occur within 4 to 6 weeks of abstinence, and then it's followed by modest gains for up to 12 months. Verbal skills tend to improve most quickly, while other domains may remain compromised for longer. So inhibitory control taking a longer time to recover, for example. So these improvements in cognitive functioning are underpinned by improvements in brain structure and function. And these improvements have also been shown for those who continue to drink in a low to moderate pattern. So while the bulk of this research really focuses on cognitive recovery following abstinence, there is also some evidence that improvements can be achieved in the context of reduction to less harmful drinking. So from chronic heavy alcohol use or alcohol use disorder, reducing down to low to moderate drinking, for example. So this evidence really around recovery really highlights how important it is to effectively treat problematic or harmful alcohol use because of these improvements that we see in cognitive functioning and brain health overall. So here we have the recommendations for treatment for older adults. And again, these are taken from the most recent Australian alcohol guidelines. They have a whole chapter in those guidelines focusing on older adults as a priority population. So older adults certainly benefit from treatment, and in some cases they tend to have better outcomes than younger people. So in particular, they tend to have higher compliance and better retention rates. So the recommendation here is that brief interventions should be employed for older people drinking at risky levels or experiencing alcohol-related harms. So when you do your alcohol use sort of screening, it's these people in the harmful to hazardous use range, which really benefit from brief interventions. So the types of interventions we're talking about are things like motivational interviewing and enhancement approaches, as well as personalised feedback from their treating doctors. There's also things like drinking diaries, psychoeducation, and active follow-up letters or phone calls specifically addressing alcohol intake, which are effective tools in reducing the amount and the frequency of alcohol consumption in older populations. So in terms of the evidence for these interventions, it is somewhat sparse. Here we have a systematic review conducted a few years ago now, but focusing on interventions to prevent and reduce excessive alcohol consumption in older adults. So as a result of this review, they found 13 primary intervention studies, and they were interested in looking at both reductions in alcohol use as their main outcome, but also improvements in cognitive functioning as a result of alcohol treatment, but they did not find any studies that looked at cognition as an outcome. So 6 of the 13 studies did show reductions in alcohol use as a result of brief intervention. There was limited evidence to indicate that these more intensive multi-component interventions with things like personalised feedback, physician advice, educational materials, and active follow-up could be more effective. But there was also evidence that really quite simple interventions, so leaflets or just alcohol assessment with advice to reduce drinking could also have a positive effect on alcohol use in older adults. So to address the lack of effective interventions specifically designed for older adults, we recently developed the online Rethink My Drink program for people aged over 60 years. So this intervention includes information and facilities for providing feedback to patients on their alcohol use, as well as tools to really aid behaviour change. And it includes information specific and tailored to those aged over 60 years. So the program is theoretically informed and it's based on behavioural treatment principles. So it offers 3 phases over these 4 different modules. Each of these modules are divided into different levels with different materials. We've got different tasks and exercises associated with each of these modules as well. So it provides a natural progression through these phases. So phase 1, should I cut down, focuses on decision making, and it's based on motivational enhancement therapy. So phase 2, which comprises module 2 and 3, really focuses on actually implementing change. So planning to cut down and then cutting down. and it uses principles of cognitive behavioral therapy and behavioral self-control principles as well. And then we have phase 3, which is based on best practice principles of relapse prevention. So we've got interactive e-tools, including a thinking drinking diary, in which users record their alcohol consumption along with emotional and behavioral triggers and responses. And we have several other interactive tools as well. And that's really to enhance engagement as well as for their therapeutic content as well. So over the past couple of years, we have been testing this intervention in a large online randomized controlled trial. So the Rethink My Drink trial wanted to see whether an online brief alcohol intervention could reduce alcohol consumption in older risky drinkers. And we also wanted to see whether our intervention could have an impact on cognitive outcomes in older adults. So really addressing that gap in the literature identified by that systematic review. So we conducted a 1-to-1 parallel group randomized controlled trial. Half were randomized to receive the Rethink My Drink intervention, and the other half just received a leaflet. The participants needed to score 5 or more on the alcohol use disorders identification test, the audit. So this is a gold standard screening tool for alcohol use in the general population, but for older adults as well. They needed to be aged 60 to 75 years. And we recruited nearly 900 older adults. And I've got to say that it was so easy to recruit people for this trial. We hit our recruitment targets really easily, really demonstrating the need for a program like this out there. So 75% of our sample completed the post-intervention assessment, so the 4-week assessment, and then 55% completed the 12-month follow-up assessment. And this really is excellent considering that all trial procedures were conducted entirely online. There was no face-to-face contact. There was very limited telephone support as well, if needed. So we just completed preliminary analyses on the data from this trial, and we're very excited about some of the impacts our intervention has had in terms of both reducing alcohol use and in terms of improving cognition as well. So we're very much hoping that this will be published in a journal near you soon, and then we'll be able to get the intervention actually out there to the people who need it. So in summary, alcohol use is increasing in older adults. Alcohol use is associated with brain damage, dementia, and cognitive impairment. These impairments may be reversible, so effective treatment really is key. And brief interventions really are the first line recommendation for the treatment of problematic alcohol use in older adults. And that's it from me. Thank you very much.
Thank you very much, Louise. That was fantastic. Lots of information about alcohol-related cognitive disorders and dementias. And I think we do have some questions from the audience already. So I'm just diving into the Q&A now. Everyone else getting inspired to asking more questions, please type them in the Q&A and I will go through them in the next few minutes. The first question is there any evidence to suggest that vegetarians or other, I guess, who are also deficient in vitamin B1 have the same level of risk of cognitive decline compared to Wernicke's disease patients?
Interesting. I'm not sure. I haven't seen anything out there about a link between Wernicke-Korsakoff's and vegetarianism. It's a really quite severe thiamine depletion that needs to be there in order to start seeing the symptoms of things like Wernicke-Korsakoff's. But I haven't seen anything out there in terms of vegetarianism, no.
Fantastic. The next question in the Q&A is, what if a patient in mild cognitive impairment with heavy ETOH, I'm not quite sure what that stands for, but maybe Louise knows. Alcohol, I'm sorry, refuses to cut down. Is there any strategies that how we can help those patients?
Yeah, so you're talking about someone, I'm assuming you're talking someone possibly beyond the scope of those sort of brief interventions, sort of heavy alcohol use disorder,
I suppose, and Sam can clarify.
People. I mean, so brief interventions are recommended for that sort of, high risk group. But when we're talking about alcohol use disorders, there's really very little out there in terms of how we treat those effectively in older adults. I mean, there are the standard treatment approaches, residential rehab, but across the board, whether it's older adults or younger adults, it's so difficult to get people engaged in alcohol treatment. To accept that they have a problem and this problem might be causing serious issues, and then to engage with treatment. The proportion of people with alcohol use disorder who actually seek treatment is really small. It's something that we need to be dealing with in terms of stigma and in terms of getting effective interventions out there as well.
I believe the question might also be in relation to the fact that you mentioned that abstinence can have a positive effect on cognitive recovery. I was wondering if there's any age effects or length of use or abuse effects on that cognitive recovery.
Yeah, so a lot of those studies have conducted in younger age groups. So a lot of the evidence comes from younger age groups and the evidence of cognitive recovery. There is definitely alcohol age interactions in terms of as you get older, alcohol has a more significant effect on your brain. Some of the primary studies included in that big meta-analysis did involve older adults, and there was some evidence that even at that stage, you can see improvements. I mean, even with alcohol-related dementia, you can, after abstinence, you can see some recovery in function. So there is some evidence out there, but again, older adults for a long time were not your priority population. When you're talking about alcohol use, it's been young men. But more and more now, it is certainly an issue with older adults, and the research isn't keeping up. We need to keep on looking at this more closely.
Okay. The next question is about the Rethink My Drink program. And the question is if it can be completed without a very little computer skills and no internet access. Is there any support for patients or people completing the program?
Yeah, there is. I mean, there is this, we're this digital literacy divide. And so the people who were signing up for the trial, we recruited them all through Facebook. So these are savvy older adults who use the internet, use social media, and know how to use, your standard internet programs and things like that. So it's not a tool that's going to be useful for everyone, and certainly not for those people who are not computer literate. On the other hand, there are statistics showing that more and more older adults are computer literate and are certainly able to meet the demands of the intervention. We've made it look pretty, but it's very much just a sort of click through. We've got the interactive tools, but the interactive tools are more for engagement. They're not necessarily needed for a therapeutic effect.
Did you experience any computer literacy barriers in the sample for your study?
Yeah.
Yeah.
So any, not so. Funnily, most of the issues came with our online cognitive assessment.
Okay.
We assessed cognition online, and that proved to be quite difficult. And there was a lot of issues with that. But not so much with the actual intervention itself, because it really is, you really just need basic computer skills to be able to go through the intervention.
One question following up on an earlier question is if you have any recommendations for patients with a diagnosis of dementia who lack insight or are unable to make decisions about the level of alcohol use or the harmful level of the alcohol use.
Yeah, so I mean, I guess this comes up into questions that, whether they are in care and guardianship and things like that. And I mean, I guess there's nothing much you can do unless it gets to that level of impairment. Okay.
Difficult still. There is another question asking if you have heard of the Wicking projects, which evaluate the neurocognitive functioning of older adults living with alcohol-related brain injury and the impact of a psychological support program.
I haven't heard of that one specifically.
The question's coming from Elise Rota Bartling. She's saying, I lead this project and some significant outcomes were achieved for those participants. So
yeah, wonderful.
been
If
linking
it's
up.
published, I'm not looking at the Q&A. I'd love to, if you have any links there.
Yes, if Elise otherwise wants to get in touch with me, I put my email address in the chat, and then I can link you up with Louise for a conversation about that.
Wonderful. Amazing.
Moving on to the next question. Does the routine oral thiamine helpful for preventing Korsakoff in person who drinks regular large amounts of alcohol?
You need to be abstinent in order for them to start. They need to have stopped drinking in order to start the treatment for those.
That's the first step and probably the most difficult. Another question asking, should the NHMRC guidelines for alcohol use include different recommendations for older age groups?
That's a tricky one. Stays
between us.
So the NHMRC guidelines are a catch-all, and the more, so there's been lots of conversation and talk about this. Should there be different guidelines for younger people, for men and for women? So in a lot of countries there are different guidelines for men and for women, but in Australia we don't have separate guidelines for men and women. We also don't have age-based guidelines, and age-based guidelines are actually very rare internationally. And I think it's because of you want a simple message that can be that a simple message out there that people can take on board. Once you start getting complex and talking about different populations and things like that, it does start to get tricky, even though there certainly is evidence that for some populations the guidelines should be varied.
Okay, much work to do. From when are the latest NHMRC guidelines for alcohol use?
No more than 10 drinks, 10 standard drinks in a week, and no more than in a single day.
And from when are they?
From when?
Yeah.
You mean when were they?
When were they published? Yeah.
They were just revised recently, I think 2020, 2021. So
okay.
They were just revised recently. And it's a huge process that they go through with those guidelines in terms of literature reviews and everything else. And it's taking everything on balance. I mean, we know that low levels of alcohol use, even at that level, may have some impacts on things like cancer, for example. But you've got all these different health conditions, you've got all these different populations. It's trying to come up with a simple guideline that's relevant to all, which is really tricky. And I think they've balanced it well there.
Yeah. There's another question from Patricia Reyes saying, our drug and alcohol services will not offer any interventions if the patient does not want help. What strategies did you use in your study to engage participants to seek treatment? What were your retention and completion rates for the program? Yeah, so the first module, I think number one, the people who are signing up for a program like this are already somewhat motivated to change. And then that first module really focuses on things like motivational enhancement and motivational interviewing type techniques, where it's really motivating the participant to start thinking about change and what's wrong with their drinking. And those sort of therapies have been shown to be effective in terms of getting people to start thinking about change. So I think that they're the therapies that have the best evidence in terms of getting people on that pathway. Retention and completion rate. So 75% did the post intervention assessments. So we're still to dive into the actual engagement data and how many times they logged in and things like that. But 75% did do the 4-week post assessment assessments, which is pretty good considering the completely remote nature of the program. Yes, definitely. And yeah, I think as mentioned before in the chats, with many virtual programs, the experiences that the more support, the better, particularly for that age group. At the moment, probably that's going to change over the next few years and decades. Okay. Alice just following up on the Viking program that she mentioned earlier, saying most of the participants could only be supported using a controlled drinking program because of the advanced level of cognitive impairment, leading to an inability to self-manage their alcohol consumption.
Yeah, look, I'm harm minimization, however it happens, whether it's abstinence or controlled drinking, as long as there's less drinking happening, I'm all for it. And like I said, there is some evidence that if you can get your drinking down to that, really, we are talking quite low levels within sort of guideline levels, less than 10 drinks a week, then you can see improvements in functioning. it does not need to be abstinence, but there again, there's more research needs to be done in terms of that low level drinking and the extent to which recovery can happen in that context.
How did you advertise your intervention, given kind of your success in engaging patients? Whereas we heard from the audience that it's sometimes very, very tricky to engage potential participants.
Through Facebook, we recruited all of them through Facebook. That was all we did. We didn't
Okay.
do anything else, and it was easy and quick, like really quick. So there's a real need for this out there. We had some, you know, comments on the Facebook ads that we ignored, but which weren't always positive. But it was solely through Facebook. We had all these other sort of methods that we'd propose as part of the ethics application that would go and use. But in the end, Facebook was just easy. You know, we did have to pay, like paid advertising for Facebook, but it worked quickly and got our target. You know, we have heavy drinkers. You know, that baseline alcohol level, heavy drinkers recruited as part of it.
Was it though quite anonymous, or did you get like identifiable information?
Nope, or not. So I think this is one of the things
Yeah.
that I look at internet related therapies across the lifespan, not just older adults, and it's one of the things that certainly younger age groups really like is the fact that it is anonymous. So for some people it's what they want. For others, there are other strategies out there that might be more effective if they want that actual face-to-face contact.
Yeah. Okay. There's just one more question about the intervention, asking why you didn't include 50 to 60-year-olds as well.
We were really inspired by that systematic review, which had not shown any, had no studies looking at the cognitive outcomes. So really, you know, we had an idea that a drinking intervention would have reductions in alcohol use in older populations, and there was evidence out there suggesting that what we really wanted to look at was those cognitive outcomes. I think the intervention will be effective for a larger age range, but just really in terms of looking at those cognitive outcomes, we wanted to keep it in the context of older adulthood when they're starting to experience that cognitive decline.
Do you have any plans already for kind of rolling out the intervention again after publication? They're still under wraps though.
No, we got social media campaigns, we got everything. That's how I think we would a direct to consumer type social media campaign. But yes, we do need to analyze the results a bit more rigorously, but it's looking at
fantastic. But definitely watch the space for everyone attending and who might need interventions, self-guided interventions for people with alcohol misuse and cognitive decline. Thank you very much for your talk and for answering all those questions. Thank you very much for everyone attending and asking all the questions. I think that was a really nice discussion. Thank you so much. And we will see each other for the next webinar that will most likely be on intellectual disabilities and will take place a bit later in the year. Again, watch the space. We will be in touch with emails. There will be a little feedback survey at the end when you close this. When you close the webinar. I'm just looking for the slides. That reminds me of what I need to tell you. So we would be very grateful for any feedback that you might have, any suggestions for other topics that you would like to hear webinars about, and we will try to reach out to speakers to fulfill any topic wishes. And the recording of this webinar will also be available on the EdNet website, as well as the recordings of all previous webinars that we've done already. So if you're in for a quiet evening in front of the computer, you can always check the website out. Thank you very much for joining us tonight, and yeah, have a lovely evening.